Should patients stop drinking caffeinated coffee after cardioversion for recurrent atrial fibrillation? And what are the latest recommendations for treatment of metabolic dysfunction-associated steatotic liver disease and primary biliary cholangitis? This and much more on today's JAMA Editor Summary. Hello and welcome to our listeners around the world. Today is Friday, November 14th, 2025. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today I'm joined by co-host JAMA Deputy Editor Dr. Preeti Malani. Preeti, the American Heart Association Scientific Sessions were earlier this week, commonly called AHA. Can you start us off with some of the JAMA content that was published in conjunction with the meeting?
Hi, Linda. First, let's discuss the DECAF randomized clinical trial by Dr. Wong and colleagues. The investigators enrolled 200 current or previous, within the past 5 years, coffee-drinking adults who were undergoing cardioversion for persistent atrial fibrillation or atrial flutter with a history of atrial fibrillation. The participants had a median of 7 cups of coffee at baseline per week, were randomly assigned to consume at least 1 cup of caffeinated coffee daily or abstain from all caffeine for 6 months. The primary endpoint was clinically detected recurrence of AFib or atrial flutter over the 6 months after cardioversion. The authors reported that the risk of recurrent AFib was significantly lower in the group who drank caffeinated coffee compared with the caffeine abstinence group.
A JAMA research summary outlines the trial with very helpful visuals. These findings might change clinical recommendations for coffee drinkers.
Linda, let's go to another cardiology study, this time looking at diet and blood pressure. This is the Go Fresh trial, which stands for Groceries for Black Residents of Boston to Stop Hypertension trial. The dietary approaches to stop hypertension, or DASH, diet has been shown to lower blood pressure in Black adults with hypertension. Dr. Jurshek and colleagues investigated if home-delivered DASH-patterned groceries with dietitian counseling could lower blood pressure. Study participants included 180 Black participants living in urban communities within Boston that had few grocery stores. To be enrolled, the participants had a systolic blood pressure between 120 to 150 milligrams of mercury and a diastolic blood pressure less than 100 milligrams of mercury without hypertension treatment. Participants were randomly assigned to receive either 12 weeks of home-delivered DASH-patterned groceries ordered weekly with dietitian counseling or 3 $500 stipends given every 4 weeks for self-directed grocery shopping. The primary outcome was a difference in 3-month change in model estimated office systolic blood pressure with several secondary outcomes, including diastolic blood pressure, BMI, hemoglobin A1C, and LDL cholesterol. The authors reported that delivered DASH-style groceries with dietitian counseling decreased blood pressure and LDL cholesterol beyond comparable monetary compensation. On average, the mean systolic blood pressure decreased by 5.7 millimeters of mercury in the DASH pattern group compared with 2.3 millimeters of mercury in the self-directed group at 3 months. However, the effects were not maintained after the intervention ended.
Dr. Mosafarian wrote an accompanying editorial about the emergence of using medically tailored groceries for blood pressure control. In fact, he emphasized that, quote, as the field continues to evolve, additional randomized trials like Go Fresh will be essential, as will thoughtful design grounded in nutrition science and public health priorities, unquote.
JAMA also published 2 studies this week focusing on familial hypercholesterolemia, one that was featured at AHA. Dr. Ballantyne and colleagues reported results from the Coral Reef Phase 3 randomized clinical trial of an oral PCSK9 protein inhibitor called Enlicitide for adults with heterozygous familial hypercholesterolemia. Previously, only injectable formulations of this class of drug have been available. Patients with this condition are at risk for premature atherosclerotic cardiovascular disease due to elevations in LDL cholesterol. However, emerging treatments targeting the PCSK9 protein can reduce LDL levels along with the risk of cardiovascular disease among this group of patients. Participants included 303 patients that received either 20 milligrams of oral Enlicitide or placebo once a day for 52 weeks. The primary outcome was the mean percentage change in LDL cholesterol at 24 weeks. The authors reported that among adults with heterozygous familial hypercholesterolemia, the Enlicitide group had a meaningful and significant change in LDL cholesterol at week 24 compared with placebo, with a between-group difference of 59.4%.
In their editorial, Drs. O'Donoghue and Marston explain more about existing treatments for familial hypercholesterolemia and the identification of the PCSK9 protein targets to lower LDL. They highlight that this trial showcases the first oral PCSK9 inhibitor that lowers LDL for this population.
Additionally, JAMA published a cost-effectiveness study by Dr. Bellows and colleagues this week. This was not an AHA presentation, but we wanted to highlight it as it is also about familial hypercholesterolemia, focusing on screening in childhood and early adulthood. Now, this is a really important issue because many individuals with familial hypercholesterolemia remain undiagnosed. In this study, the investigators considered the cost-effectiveness of population sequential familial hypercholesterolemia screening. This is lipid testing followed by genetic testing after a high LDL cholesterol measurement. They used a computer model, the CVD policy model, to estimate outcomes based on screening at age 10 or 18 years of age. The main outcomes were direct healthcare costs in U.S. dollars, quality-adjusted life years, and an incremental cost-effectiveness ratio. The authors found that sequential screening strategies were not cost-effective relative to usual care.
And in his accompanying editorial, Dr. Gilman offers some context on the controversy and complexities of childhood cholesterol screening. He emphasizes that pediatric clinicians can rest assured if they do not recommend universal lipid screening for their patients without pertinent family history of familial hypercholesterolemia or premature cardiovascular disease.
JAMA Deputy Editor and Internist Dr. Mary McDermott and colleagues contributed the PERMIT randomized clinical trial, also presented at AHA. This trial assessed whether metformin improved walking ability in patients with lower extremity peripheral artery disease, or PAD. Few effective therapies improve walking performance in patients with PAD, and metformin is widely available and inexpensive. The authors randomly assigned 202 patients with PAD but without diabetes to receive metformin or placebo for 6 months. The 6-month change in 6-minute walk distance did not improve with metformin compared with placebo, which was the trial's primary outcome.
Also at AHA, in the TOP trial, Dr. Kuyas and colleagues compared postoperative hemoglobin transfusion thresholds for patients at high risk of cardiac events after surgery. More than 1,400 participants across 16 Veterans Affairs medical centers in the U.S. were randomized to a liberal or restrictive transfusion strategy after major surgery. The transfusion threshold was hemoglobin level less than 10 grams per deciliter or less than 7 grams per deciliter. The primary outcome, a composite of 90-day postoperative death and major ischemic event rates, did not differ between the two groups. Dr. Jacobs and colleagues provide context for this trial and discuss how these findings may aid clinicians in selecting transfusion thresholds for this patient population. They call attention to the many nuances of this clinical decision, noting that point estimates for the composite of the primary outcome consistently favored the liberal transfusion strategy.
And to round out AHA content, there's a cohort study from Sweden about coronary computed tomography angiography, or CCTA. CCTA can provide information about a patient's heart disease risk, including characterizing non-calcified coronary atherosclerosis, in addition to identifying calcified plaque and the degree of coronary obstructive disease. Dr. Bergstrom and colleagues investigated if CCTA could help improve risk prediction in primary prevention of coronary events for older adults. They included over 24,000 CCTA images from individuals between the age of 50 and 64 without previous cardiovascular disease. The authors found that the addition of CCTA data to traditional risk factors and coronary artery calcification score modestly improved prediction of coronary artery events at 8 years of follow-up.
Preeti, let's move on to the JAMA viewpoints. Katie Farku and colleagues explain how the One Big Beautiful Bill Act could impact federal loan caps for medical students. And in their viewpoint, Dr. Frieden and colleagues advocate for more definitive recommendations on COVID-19 vaccination from the CDC. And in another viewpoint, Dr. Mozaffarian and colleagues discuss the strengths and weaknesses of the recently proposed Make Our Children Healthy Again strategy.
And Drs. Makary and colleagues at the FDA wrote a viewpoint about the need to revisit menopausal hormone therapy labeling for products including estrogen and other hormonal medications used for the treatment of menopausal symptoms.
Clinicians who counsel patients and regularly prescribe these medications, especially vaginal estrogen, will be interested in the FDA's plans for relabeling.
Don't miss the JAMA review on metabolic dysfunction-associated steatotic liver disease, or MASLD. Dr. Tilg and colleagues focus on the signs, symptoms, and evidence-based treatments for MASLD in adults. For more on MASLD, tune in to hear JAMA Deputy Editor Dr. Kristen Walter discuss this article and liver-associated complications with review author Dr. Stefan. Let's hear more from Dr. Stefan.
So moving on to behavioral modifications, we know that's the first-line treatment for MASLD. Can you discuss dietary and physical activity recommendations and how effective are they?
The best data comes from studies that addressed weight loss. And it's commonly accepted that a weight loss of about 5% is quite effective of reducing about 20-25% of steatosis. 7 to 10% weight loss is necessary to reduce to a considerable amount inflammation, and 10 to 15% is now necessary to really reach a regression of fibrosis. So weight loss, particularly in overweight, in obese people, about 10%, let's say that, and in some people higher, is very effective. We know that also a modification of lifestyle and the diet without weight loss is effective. And here is particularly the modification of the diet, moving more to a Mediterranean-like diet, meaning healthy oil and fats, a reduced intake of saturated fat, particularly from meat, and particular reduction in fructose and glucose also can have pronounced effects on steatosis and also inflammation without any weight loss. So the recommendation is in overweight and obese people to reduce body weight, aiming at about 10%. But in addition to that, the modification of the diet is also effective. And the last point, certainly, the increase in physical activity is also helpful to achieve an improvement of the MASLD.
Speaking of the liver, Dr. Tana and colleagues contributed a JAMA Insights on primary biliary cholangitis. It's a helpful read to stay up to date on this rare chronic autoimmune liver disease.
And with that, there's also been a lot of rapidly developing medical news. Our outstanding JAMA Medical News team stays on top of it all and gets you the latest articles in clinical medicine, biomedical research, public health, and health policy. Find it all at jamamedicalnews.com or click on the link in this episode's show notes. And if you'd like more AHA content, look for a special edition of the JAMA Editor's Summary as Drs. Greg Kerfman, Bob Bono, and Phil Greenland discuss JAMA Network papers featured at the AHA meeting.
Thanks, Preeti, and thank you for tuning in to hear what's new this week at JAMA. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens, Ella Barnes, and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.